All right, hello, welcome back. We're now in the second part of this microbiome series, this oral microbiome series. And in this episode, we're going to talk to address some of the claims where some people say, quote, all mouthwashes are bad because they wipe out the oral microbiome. Disagree with this? Well, we're going to look at a few studies that may change your mind. So, hello again, I'm Dr. Rob alongside my co host Tami, and you're listening to the Dental Formulators Playbook.
So, in episode 11, you gave a good overview of how the oral microbiome is supported with nitrates. But this is a huge, huge topic, and we need more insight, especially from the formulation perspective. You're a big believer in multi species involvement in decay, such as the combination of S. mutans and various lactobacilli species for caries, correct?
Yeah, that's right. And so the formulations and different active ingredients were kind of, if they're done correctly, if they're done according to, for instance, the OTC monograph, they've been done because, and they've been made that way because they've been made effective. It's been seen that way clinically. And in the clinical situation, you have more than one species. Unfortunately, there's been a lot of research and stuff that only looks at one species. If you do a kill time test, it's against one species. If you do a minimum inhibition, concentration test known as MIC or minimum bactericidal concentration, these are MBCs, MICs, standard entry level biological assays done on how many species?
One. But how
One,
did you say we're in the mouth?
over 700. And there's going to be significant interplay among certain types of bacteria. So, for instance, there's two separate research groups that I think have done a really good job of this. Caulfield is one, and Wen is another one. And you could, Google them. They have some really nice papers about this, but they talk about, for instance, Streptococcus being a great biofilm former. Like we know this, we even talked about this in episode 11, right? We said, hey, look, streptococci really make up a lot of the biofilm formers. Actinomyces is also another one. That's usually around the gum line where there's a change in border, right? You go from smooth surface enamel to all of a sudden soft tissue gingiva, the keratinized tissue that we talked about last episode. And there, the actinomyces seems to better thrive than some of the streptococci species. Anyway, the point is, if lactobacilli is involved, which it is, we talked about that even in the 1920s, 1940s, they found in caries decayed teeth that presence of lactobacilli, then you would have to think, well, then they're going to be there together. And they are. The lactobacilli loves creating the acidic environment. How do they do that? Lactic acid is created through fermentation of the sugars that they consume. The streptococci, yeah, they can also do that too. It just takes a longer time. Lactobacilli are just like that's their superpower. Take it, make that acid, get it acidic, boom. Superpower of the streptococci is let's form some biofilms. Let's create the home so we can get stuff going. So that is kind of where this discussion's kind of taken us here,
Okay, so you mentioned the biofilm. So what's the composition? What's the biofilm made up of?
Yeah, so there's this thought, and not everybody subscribes to this, but if you believe it, and I think a lot of researchers do, it's called the ecological biofilm hypothesis. And this is where you're going to talk about that there's more than one player. There's more than one
Yes.
bacteria causing either harm or benefit, whichever. And a really nice review of this has been published in 2015 by Aruni and others in the current oral health reports. And this is an open access journal, so anybody can access this. And I think that this has a great overview. They first talk about, hey, you have your initial colonizers like streptococci and actinomyces. Like again, streptococci forms about 80% of the biofilms on the tooth surface, and that's a lot,
Yeah.
right? And then you have linker microorganisms and bacteria. Speaking, that would include like fusobacteria, maybe even some Prevotella. They start to get recruited. There's such things called quorum sensing and such. Certain bacteria are recruited over others because of favorable properties. That's just the community. And if it's going to be a good community, then they're going to have those species that favor that good environment. However, if it starts to turn pathogenic, and that's only whenever you have opportunistic
Right.
bacteria that are already considered commensals because they're already in our bodies, right? We already have them. We didn't all of a sudden get them because we stuck ourselves with a nail and there happened to be, or something that had a different species of
Right.
bacteria on it, right? So the commensals among all the commensals, there are some that are opportunistic, and if they're pushed a certain way, they can get to be pathogenic. And so in that third stage, on top of these of this linker level, like where you have the fusone prevotella, just as an example, you might have some Tannerella, you might have some Porphyromonas gingivalis, which you'll think about as, hey, gingivitis, gingivalis. Boy,
Yes.
there's that relationship. I wonder
Yes.
why it's called, that. So
So you did mention in a previous episode that, and I just want to remind people because I've never thought of it this way, and it was eye opening for me that most of, as long as things are in balance, things being bacteria or whatnot, then it's considered commensal. It's fine as long as it's in balance. And that dysbiosis is when,
symbiosis would be a better way to say that, a
perfect,
balance. Commensals are just whatever we have in our bodies.
that doesn't
Again,
do us harm.
yeah, that it takes us back to that nail analogy. There was some weird bacteria on the nail. We poked ourselves, all of a sudden now we have something. That bacteria would not be considered commensal because we already have commensal. We have commensal on our
Okay.
skin, on our hair, in our eyes, in our bodies, in our guts, and yes, of course, in our mouth.
Okay.
And so we need those. And we talked about in the last episode the power of the nitrate reducing bacteria
Yes.
to try to provide some nitric oxide production. We talked about that having some physiological benefits. But whenever these biofilms are left for either too long or they become dysbiotic
Right.
because you're getting some recruitment of some bad actors, then you have a problem.
They're getting enticed, basically. The commensal are getting enticed to step to the dark side, for lack of a better word. So that would automatically mean that that's probably more likely to be like a disease state, then, correct?
Yeah, that's right. So whenever you start having issues, and these things can happen so quickly. I mean, if you're eating a salad and it has chia seeds in it, and you get one of those seeds stuck in between your
Yeah.
teeth or under a crown
Yeah.
or, in your orthodontic appliance, whatever it is, all of a sudden that becomes hydrated, right? The chia seed, and it begins to gel, right? I mean, that's
Yeah.
what
Yes.
happens. You can actually put water with them and it's like the chia pet, right? It's like
Right.
that commercial, right? It can grow too. And well, that's the same thing. So it just sprouts essentially, and then it can, start to form networks, and you're not going to want that. And the commensals are going to take issue with that. But the opportunistic ones, among those might say, hey, let's have some fun now. Now we have an opening. I'm kind of hungry for some protein and I want to start attacking the gum line. And so these are just some of those examples. So again, this isn't just because of somebody's genetics, although that's a real issue. It's not just because of
Hmm.
a diet. These are just accidental things. Another one is abscess teeth, man, that you can get
Hmm.
if some kind of endodontic procedure goes south. It
Hmm.
happens. A paper that was recently published in 2015 showed this, and it wasn't that you had the bacteria from the dental burr or the drill bit or any other
Hmm.
kind of introduction from some iatrogenic factor from the clinician. It's just that all of a sudden something was done different, and that those opportunistic species then all of a sudden got tilted a different way. You have dysbiosis. So interestingly, with respect to that, and so what do you do? Well, if it gets that bad, then you need antibiotics, right? To try to do that.
Correct.
Obviously, those are a broad spectrum, but everybody knows, I mean, antibiotics don't, you take them for a week, 10 days, maybe 14 days. Yeah, everything gets wiped out, but then everything comes right back. And
Yeah.
I
Right.
think that that's
Yeah.
a good thing to remember because we're actually talking about antibiotics. And so some of the mouthwashes and stuff that are being used aren't that potent, relative to antibiotics,
It's a great analogy.
with some exceptions of being maybe chlorhexidine. Chlorhexidine is pretty aggressive. Hospitals usually have that. They use that to clean tools, sometimes wipe surfaces, even clean their gloves if they have gloves on and such. But that's kind of getting phased out in the oral care stuff just because we talked about it, discoloration of the teeth, and it is wiping out everything. And do you really need to wipe out everything? Probably not. The chlorine dioxide gas is probably another one that, can be
Hard.
unpleasant. You know what I mean? Nobody likes smelling well, maybe they do. I mean, smelling the chlorine. I know if we open up our bucket to the chlorine tabs, all those pucks that we put, especially if it's on a warm day, and even though if you might keep it inside, still things might get heated up. I mean, you're gonna get that mustard gas like
Mm-hmm.
coming right at you. Not that chlorine dioxide gas is that as potent, but there's
Similar effect.
yeah, it's obviously going to be attenuated a bit, but that's the analogy,
Okay.
And is that nice? No.
No, right. So, in short, it's probably very important to keep our oral microbiome healthy and
Yeah, of
clean.
course, naturally.
So, this is going to rely in a large part on healthy diets
Yes, we talked about that.
and behaviors such as, I don't know, good hygiene behaviors, brushing your teeth, whatnot, and whatnot. That helps to actually minimize those plaque traps then where the biofilms and stuff can accumulate.
Yeah, keeping the teeth clean is the number one way to prevent decay, and this has long been discussed. I mean, I can remember seeing research papers back in the 1960s about this. If I had to go back and look through the research, they all said, "Hey, keep your teeth clean." But again, it's hard. If you have that salad and it has that chia seed, you're gonna have to immediately floss afterward or something,
Hmm.
to make sure you get that out. And that's just what you know about. Anybody with orthodontia, if you have any crowns, implants, if you have a partial, if you have fillings, if you have any other dental apparatus, if you wear a retainer, for instance,
Even Invisalign.
even Invisalign, we're going to start having plaque traps evolve over time. All these present opportunities for biofilms to not only colonize, but then grow.
So, keeping your teeth clean, flossing, mouthwash, brushing, etc., is of primary importance. But let's discuss this more besides chlorhexidine
Hmm.
and this bleach-based
Hmm.
mouthwashes, which you said were clearly they're harsh, they're more damaging to the microbiome. Are conventional oral care products just as bad for the oral microbiome?
I think claims that certain products, again, outside these bleach-based or chlorhexidine, are any claim that these things are bad for the oral microbiome, I believe is absolutely wrong and is either ignoring the strengths and limitations of certain active or inactive ingredients in the product, or they're just simply ignorant and they're just going with the flow, right? The trends just say, hey, look, consumers want this, consumers want that. How do you know what consumers want, right? You're kind of leading them down
Mm-hmm.
the path. If you tell a consumer, look, do you want something that's been safely tested and clinically tested? Sometimes they go hand in hand. Has this been reproducible? Is it reproducible among different sites, like whether it's different companies or different academic labs or other
Mm-hmm.
kind of contract testing labs? Is there a monograph for this? Like, do we have the levels? If we say, oh, this is an ingredient, well, what's the right dosing? We talked way long ago. Paracelsus really, taught us this, the dose is the poison in a formal way. I mean, that's what toxicology then is about, it's the dose that
Right.
makes the poison. We can't say water is good because too much water and you'll drown,
Yeah.
right? Or you'll dilute your body of mineral if you drink it just obsessively. So it's the dose, it's the dose, it's how
How
it's
much you take.
yeah, it's how it's put into the formulation because again, you have to worry about dilution. You have to worry about substantivity. You have to worry about other factors in the mouth, maybe even like proteases, things like this that can break down certain ingredients. Therefore, we can't use that, very well in a formulation. So although there's gonna be a lot, and again, this is based on trending and people are wanting to have alternatives, that's fine. Well, I'm not against it. Make sure that you get that stuff tested and not just in very simple tests, right?
Right.
So a lot of times this is originating from the entry biological testing that's usually considered to be planktonic, meaning it's only on
One species.
one species. You have kill time tests, you have inhibition of growth, you have bactericidal, and they're all done either, they have some broth or they have a petri dish and they just put, just the purported, active ingredient and they,
So these tests just look
and
at
they look
one
at,
species.
yeah. And so when
How
you
much
do
did you
that,
say were in our mouth again?
over 700. Yeah. So
Okay.
so there's a lot. And even if it's just 700, the arguments are then somebody will say, well, Rob, the monograph actually specifies that there's about 5 or 6 of these pathogenic species that are recognized for decay. Hey, that's true. Okay. You don't have to do all 700, but wouldn't it be nice if you had combinations of maybe two? Because Streptococcus and Lactobacilli, powerful combination,
Once they're
right?
combined, they act much
I
differently.
mean, yeah, I mean, when in his research, Caulfield has also showed this, they just talked about that. With if you have streptococcus in the presence of certain lactobacilli species, even in just simple lab-based studies, planktonic, but just with two species, all of a sudden you'll get an increase in not only that lactobacilli species that grows, but you also get S. mutans that grows as well. And there's some species that will not augment maybe S. mutans, but it will augment just that lactobacilli species.
Hmm.
These interplays, it's really hard to predict. You can't
Yes.
necessarily predict these strongly. And that's why clinical studies ultimately are going to be the gold standard to whatever active ingredient.
Makes
And so the
sense.
conventional ones that we'll mention today are going to be those that are found in the monograph,
Okay.
cetylpyridinium chloride and Listerine. And both of those have been well researched. There's lots of clinical studies out there on them. There's monographs that stipulate exactly how much you can have and in what format these can be in. So somebody might say, "Hey Rob, I have an idea for essential oils in a toothpaste. What do you think?" And it's going to have a great effect, and I'm following the monograph. False. Okay. It just won't have that. You can't just put that in a toothpaste. It has to be in a mouthwash. If somebody says, well, I want to put cetylpyridinium chloride in a toothpaste, that's my question voice, right?
I think so.
If they say that, well, we can say you can do it. I mean, Scope is a great example. Procter& Gamble has a Scope Crest toothpaste. Usually it's travel size, and CPC is sometimes in there, but it's in there not as a active ingredient. They list it as the inactive ingredient, and maybe it has some preservative properties, for instance.
Okay.
So if you're going to make active ingredient claims against certain bacteria that are known to cause disease
Mm-hmm.
or are implicated somehow in disease like gingivitis, then you have to stick with that. You have to make sure that the clinical testing is good, that the product adheres to that range, and it has been tested. So, and yes, you can still use some lab studies to try to get there. Really, whenever I talk to people about building up a formulation, it's really creating a dossier of what you're doing. If somebody
Okay.
says, "Hey, I want to make a toothpaste or I want to make a mouthwash that has whatever," well, let's start building that dossier of tests. Are you going to need a preservative in your formulation?
Right.
Are you going to do any kind of performance testing?
Mm-hmm.
Is it going to be having a pH that might be considered to be demineralizing and therefore destructive? Well, there's an ISO test method that will look at that to make sure that you're not actually eroding enamel, you know?
Yeah.
These are just some of those things. So cetylpyridinium chloride we'll talk a little bit about, and Listerine, the four essential oils with the alcohol. We'll also, just I'm not going to get into the nitty gritty of the ingredients. We will in the next episode. Although this is just the part two, just the microbiome. We're gonna look at some of these other ingredients a little bit more closely in our next episode. But
There are
yep.
examples then where here's what you've been talking about: essential oil mouthwashes like Listerine.
Mhm.
Um, would you then say it is less damaging than
Yes.
chlorhexidine?
Yeah, absolutely. So I think that this is a really good place to start, right? What are the expectations? What is known?
Yes.
Unfortunately, some of these tests, and I've seen some of these publications, and they link or they say maybe there's some kind of correlation, maybe it's loose, or maybe there's some association. They'll say mouthwash use will lead to higher blood pressure, but they don't make distinctions on what those mouthwashes are. So there are so many mouthwashes. Moreover, depending on where these studies are being conducted,
Hmm.
there might be marketed products that aren't available here in the US
Right.
or in that area where the study was actually conducted. This is very common. Sometimes you just don't have the same exact products. Overseas, chlorhexidine is found in lots of mouthwashes. Lots. Here in the US, it's going to be really challenging to find an over the counter mouthwash that has chlorhexidine.
Okay.
Unfortunately, and if the trends are here and people want to sell products or they want to get you to be a new think, I get it. You're trying to attract listeners or whatever. I don't know, whatever you're trying to do. But the point is, there aren't any chlorhexidine mouthwashes available for sale, as popular in the US as there are cetylpyridinium chloride or Listerine. And if there are, hey, I stand corrected. But I'm telling you, based on the monograph and what we have and what you can find either online or in the stores, there just aren't a lot of those. So I think that lumping all of these mouthwashes in general are bad, That's what happens. The study is done overseas. They look at these mouthwashes. This is especially popular in Europe where chlorhexidine mouthwashes are used. And that actually takes me to this paper that I want to talk about right here because
Okay.
this was a good one. This was a 2023 paper that was just published. In 2023, but it was published in the open access journal Frontiers in Cellular and Infection Microbiology. And it was by Liu and coworkers, and they detailed the clinical findings when hospitalized patients in Taiwan. Okay, so now we're talking
Hmm.
about, again, outside the
Right.
US. Again, here in the US, can you go right down to the Walmart or to the Target or to the CVS or wherever and get your chlorhexidine mouthwash? It's going to be challenging. Okay, you're likely to find Listerine or some kind of CPC based
Hmm.
mouthwash. Anyway, they took these patients who were hospitalized for whatever reason, okay, and they said you get to toothbrush as you would normally do if you do. We're not going to even control that. We're not going to get it in
Okay.
any kind of interruption with that. But we're going to give you either a saline treatment, we're going to give you a chlorhexidine treatment, like 0.12%, which is very common, absolutely, in some of these mouthwashes, or we're going to give you a Listerine Total Care mouthwash.
So you're saying when you say treatment, you mean the mouthwash that they're going to
Yes.
squish with in addition to brushing their teeth.
Yes, that's right. And the Listerine Total Care mouthwash, again, I don't have all the details. I don't think that they necessarily listed them. Though if it is the same one in Taiwan as it here in the US, then the Total Care has been remodified to also have a little bit of fluoride in it. It does still have alcohol and the four essential oils that make up
Okay.
the Listerine. And so I think that that would be the same one. Anyway, it has 30 people per groups, and there was enough for significance if they were to do those comparisons, which they did, of course.
Okay. So you said they were allowed to toothbrush, correct?
Yep.
Not just mouthwash only.
Yeah, they were allowed to. If they participate in toothbrush, then you do your toothbrush. If not, then you're not. If you want to brush your teeth, 3 times a day, then fine. But the thing that was fixed and that all the patients had to do was they had to mouthwash twice daily.
Okay. So in the previous episode, we talked about how the oral site matters for bacterial composition. We discussed there's seven different locations where they have extracted,
Yeah, that's right.
samples to try to
Saliva or the palate
correct.
or the
Correct.
cheek. Yes, that's right.
So in this particular study, then, how did the researchers collect the bacteria?
Well, saliva is a great biomarker, right? I think some of the other researchers mentioned that in that report that I mentioned in the previous episode. So what here is they did is they allowed the people to use the mouthwash, and then what they did, and this was in the mornings and such, before maybe they had their breakfast and such, they would have them swish with some saline solution and then gargle with that and then spit it out, and then they would take that and they would analyze that. So they're
Okay.
so they're getting kind of a representative, feel of all of the different sites in the mouth.
Okay. Okay. So was this a short-term study
Yep.
or
Yep. They had it at baseline, and then they kept people. Well, they didn't keep them. The people were either there for either 5, 6, or 7 days, and so
because these are hospital
yeah,
patients?
because they were hospitalized, and so they just did that up until the point where they left, no later than 7 days. And they looked at both chlorhexidine and Listerine, and of course, a saline control. Three groups, 30 people each.
Okay. And the mouthwashes, did they lower the bacteria levels?
Yeah, absolutely. They both did, right? And, is that surprising?
I wouldn't think so.
No, yeah, it's not surprising, and you're going to get some reduction in levels, especially if it's that short term, but there were differences.
So there is something else, right?
Absolutely. The Listerine group overall had a much smaller suppression of microbes compared to the chlorhexidine, and different genre were targeted.
Okay, so if I heard you correctly just now, you said that chlorhexidine and Listerine then affect the microbiome differently.
Yes, absolutely. And in fact, one suppressed more nitrate reducing bacteria than the other one.
Which one?
Well, what do you think?
Well, I would think that chlorhexidine is the harsher of the two, right?
Yeah, so the chlorhexidine is the harsher of the two, and it did. It had a
Okay.
greater reduction of nitrate reducing bacteria, whereas Listerine had more of a muted effect.
Okay, so tell us more.
Well, that's pretty interesting, right? So right
Yeah,
there within the first 7 days, so even using, there's two differences, right, that were clearly observed between chlorhexidine and Listerine.
right.
Listerine did not have as damaging effect as chlorhexidine. For me, I mean,
That's definitely
this is
worth
completely
repeating.
independent. Well, it just shows you that there's differences in mouthwashes. So
Yes,
we can't unilaterally say all mouthwashes are bad for the microbiome, which is the trending that is going on right now
right.
and some of the push. It helps to understand which mouthwashes are bad. And one of the reasons why we're saying this is because look, if you want to have a product and you want to sell in the US market, you have to understand the monograph. Number one.
Hmm.
Number two, from that point, you might be able to adapt what you want in your product by taking aspects that just might be functional and workable in some of these other mouthwash, and then kind of create maybe a hybrid or
Hmm.
create an opportunity where you're not necessarily, it's not all or nothing,
Right.
right? There could be shades of gray. There's a lot of shades of gray.
Mhm.
And if you really do go completely outside the realm and say everything else is bad, but this is good, you're going to get extra scrutiny because what you're saying, especially if it's not tested. If it is tested, or even if it isn't tested, but you're outside the norm, you got to make sure that you have enough high quality testing and that you know the mechanisms in place for
And
really trying
appropriate
to
testing.
stand. Yeah. So if you believe all this other stuff, is that enough for you to die on that hill? Are you ready for it? Do you have enough clinical studies? Did you do enough lab studies? Do you have enough core data on your end product that shows this? I think that that's really important. A lot of people just sometimes they just come into this, right? They just learn about it. But Listerine has been around for a long time.
Yeah.
We'll talk about this in the next episode, perhaps, or maybe we won't. But Listerine originally, the formula wasn't even for oral care. Somebody else already beat them to it. Sozodon did that in the late 1800s. Listerine was maybe for hygienic care, women's like care. You know what I'm saying?
Yep. Following.
So it's not like the Listerine is like, just 20 years ago and just 40 years ago.
Right.
And maybe there's just, I don't know, one clinical study done on this. These products and these approaches have evolved in time and they're continuing to evolve. So yes. So there were differences between chlorhexidine and Listerine. I know I'm going off on that just because, well, I mean, it's important
It is.
for those that are listening. We cannot treat all mouthwashes as bad. Just we can't do it. There's certain purposes of this.
So far, that is definitely the key takeaway.
Oh my goodness. Yeah, it absolutely has to be. Okay, so let's talk about the upper respiratory tract because with respect to this study in Taiwan, that's what they were looking at.
Okay.
They were looking at those patients that maybe have higher levels of certain bacteria that are associated potentially with pneumonia. And two of those are Rothia and Prevotella. In fact, they're not both high, but Rothia levels tend to be higher, while Prevotella tends to be lower relative to people that are healthy. So if you have pneumonia, you might have a little, or any kind of upper respiratory
Hmm.
issues, you might start having an imbalance where you have a little bit more Rothia and a little less Prevotella.
Okay. So compared to healthy people, then Rathia is high and Prevotella is low for those that have that upper respiratory tract and
Yes,
those issues.
yes. Well, after use of the chlorhexidine mouthwash, Rothia further increased and Prevotella further decreased.
So it exacerbated it.
So it just exacerbated it. So that's where some of this stuff is like, hey, chlorhexidine might not be the best choice here. We can understand that. To me, that right there in that study,
Makes
just,
sense.
yeah, it just makes sense. It says, look, there's going to be some augmenting behavior with the chlorhexidine that we don't want, right? So that happened there. It tilted it to be more dysbiotic and it just creates more problems.
Okay, so again, you just said it. No, the Cloroxane mouthwash actually made such a situation that much
That
worse.
much
It
worse.
tilted that microbiome
Yep.
biome even more towards a problematic state.
Yes.
Scarily, one associated with pneumonia, like or an upper respiratory tract.
That's
So,
right.
what do they find with the Listerine then?
Well, Listerine and the negative saline control that they used, and again, I like this study because they had a negative control. Okay. They did not alter at all the Prevotella levels. So they did not drop them. Okay.
So,
So that sounds good because the Prevotella, that's one of the keys. Some people might say also that the Rothia has nitrate reducing ability. And yeah, some species within the Rothia
Right.
do. Again, the Rothia is just the whole class.
Right.
Not every individual strain of that Rothia or even the Prevotella are going to have the same nitrate reducing potential. But with the Prevotella and what they found here, that one's they did not they weren't diminished, and those were the ones that they said, hey, look, that's affiliated with the nitrate reducing, you know, situation that we want to try to foster. So yeah.
So I'm seeing your point. And through everything you've just said, it sounds like that messaging around essential oils is inaccurate at
You
best.
know,
It's horrible.
yeah, and it can be, and and again, the dose makes the poison, right? We have
Yes.
to go back that Paracelsus, right? I mean, one of the original toxicologists and wasn't recognized like that, but he was. I think he was Paracelsus was just one of the just medicine men, like just one of your
Hmm.
humanists, really, right? And of course he, you know, naturally wanted to find ways of turning things to gold, right?
Of course,
You know,
alchemist, right?
alchemist, right? He was also involved in that. But the whole point is it's the dose that makes the poison.
Yes.
So I even talked with some of my colleagues in some of the big firms, some of the big oral care firms, and they even say, look it, if you're putting in flavors in certain products, you really shouldn't exceed a certain level. You know, if you're putting in too much flavor, maybe greater than 1.5, I'm just throwing a number out there. If somebody wants more precise information, we can always work on that. That's fine. But 1.5% or higher, you might start to have adverse events. Now,
Okay.
that doesn't mean that it's going to happen. It just means that it could happen. And some people, for instance, we even talked about this, are more sensitive to baking soda,
Yes.
especially if you put baking soda in with some carbonates that are meant for whitening. You know, you have these
Hmm.
percarbonates, so sodium percarbonates, and it has already a higher pH. There can be some irritations in the mouth just from that. So, all of that bears on everything that we're talking about. I think that if there is messaging that essential oils is horrible, again, the dose makes the poison, and we have to understand the levels. And everybody's going to have certain sensitivities or not. You know, for
Hmm.
most people, they probably don't have the sensitivities,
Right.
at the levels that are currently in products. And by the way, a lot of those essential oils are often found with alcohol, and the alcohol content's about 22%
But everyone attributes it.
to the essential oils if it's in a Listerine. Now, there are Listerine versions that don't have the alcohol. We'll talk
Okay.
about that in the next episode.
Perfect.
But, that also could be one of the reasons why somebody may have aversions to essential oils. And they might point to it and say, well, it's alcohol.
Right.
We will share some examples of
Good.
how effective actually some of the testing that we had done um, on that. But yes, so I think that based on this kind of study, I know it's short term. It's just one example, though. It shows that Listerine is at least safer than chlorhexidine and yet still can have a benefit.
Okay. So you had mentioned CPC before.
Hmm.
So are there any, because we just kind of touched on the essential oils versus the chlorhexidine. So are there any studies showing actual benefits to the microbiome for
Yeah.
chlorhex or not chlorhexidine, but CPC?
Yeah, and I'm gonna come back to the Listerine, I think, at the end of this podcast if I don't remind me.
Okay.
But with respect to the CPC, yeah, three separate clinical studies. One was done with the toothpaste. Again, not really sure how I feel about that, but one was done with the spray, and then one was done with the mouthwash.
So even a toothpaste.
Yeah, and these are completely independent studies. These have been recently published. I don't know how stable, or I should say, how available the CPC is in a toothpaste just because CPC has significant sensitivities with other ingredients. If one were to ever mix that with a poloxamer, and again, we'll talk about this in the next episode, you have to be careful because certain interactions can exist. And it's not just poloxamers. It could be your normal solvents that you would typically use to try to mix in oils and into a water-based
Right.
formulation. Sometimes they call those oil and water formulations. How do you get, for instance, spearmint oil into a
Mm-hmm.
water-based formulation?
Yes.
Oil and water traditionally don't mix at the levels that are used, and you can get some separation. Well, there's certain ingredients,
Mm-hmm.
that are available, certain solvents that really help to pull that stuff in. And some of these, I'm thinking of PEGs, right? PEG 40, PEG 20, these hydrogenated castor oils, great example of that. That's what's historically have been used to do that. You can use some of the newer ones. Propanediol is one of my more favorite ones. I love
Mm-hmm.
I love that. I love that one. But traditionally, some of these other kind of solvents, and but they also have some foaming characteristics, so you might also consider them a little bit more surfactant too. They can compromise CPC. So in a toothpaste, where the water content is even further reduced, and then you might have the presence of even other ingredients.
Right.
Speaking of surfactants, sodium lauryl sulfate, that and any other negatively charged surfactant will interact with the CPC in a negative way, reduce its potency against bacteria. So there was always that risk. Now, I don't know the details of what was in that toothpaste that we're talking about in
Mm-hmm.
the study, in this 2025 study, but it's still a very good study. It's again open access. It's in BMC Oral Health, and this was Spanish researchers. I believe it was Iniesta and coworkers, if I can remember. They looked at the subgingival microbiome of 116 patients, and it was over a 6 week period. So it's in not really a long period, but not a short period. It's like kind of an intermediate.
Okay.
What's really neat is that they looked at two pastes, one with CPC and then one that did not have CPC, but instead had sodium monofluorophosphate.
Okay. MFP?
Yeah, sodium monofluorophosphate,
Okay.
and which, as you'll recognize here in the US, that's one of the three approved
Yes.
fluoride sources for what?
For the OTC monograph.
Caries,
Carries.
right?
Yes.
So that one is for the caries. Note that that's not the version that is for gingivitis. Remember, stannous fluoride is for gingivitis. So
Okay. Okay.
as our listeners are trying to rack their
Keep
brains, right?
True. And I've been married to him for quite some time now.
No, but that is, they looked at two toothpaste, right?
So what'd they find?
Okay, so what they find? Well, first of all, they said, geez, the oral biome wasn't altered very much at all. Like
Hmm.
even in the two groups, there were some observational differences that were significant, but by and large, it's not like you had like a chlorhexidine effect wiping
Okay.
out everything, and while the other one didn't do anything. It wasn't a black and white kind of result like that, but they did notice some differences. And the with respect to the CPC, it did reduce Agarigatorbacter and Fusobacterium nucleatum, both of which are associated with gingivitis, maybe even some perio-related issues. Again, they looked at the subgingival areas of these 116 patients, right? And they split them into groups and stuff. And so those would be potential commensals that had the opportunity to become opportunistic and then pathogenic, right? And they said, hey, wait a minute, that CPC paste actually significantly reduced at least two of those species levels. So that's a good result, right? So
Yes,
so
absolutely.
they did find a good result. The ones that were acting bad, some of them, right, were reduced a bit. Now, the interesting part about this is whereas the MFP there weren't any differences. Like it didn't reduce it,
Oh,
which is
okay.
also actually a good result. But there was a significant increase in firmicutes, and you might not think that's a good result, but those were really the main observations. That's really not much of anything. That just shows you that MFP is not designed in a fluoride toothpaste to be an anti-gingivitis active ingredient.
It actually supports that. The study supports
Yeah, it
that.
supports that. And it supports that whatever, because it's not just MFP in the toothpaste, it's everything else in there too.
Right.
Surfactants, abrasives, humectants, flavoring systems. Not all of that destroyed the microbiome, right? So just because you're using a
Hmm.
toothpaste, you shouldn't be concerned, even if it doesn't have CPC or whatever the essential oil, it's not necessarily going to wipe out everything in your mouth. I think that is a really, really important aspect of this.
So that study did confirm that basically, which researchers have known, MFP is not approved for the gingivitis, correct?
Yeah, I mean, they did find that, that the Prevotella intermedia, the Tannerella forsythia, and the Porphyromonas gingivalis, those are all associated with the quote unquote red complex. That's like the final layer of the biofilm. You have
Okay.
your initial, then you have your linkers, right? Then you have your top ones that can easily get, swayed to becoming more
Hmm.
pathogenic. None of those were altered by
Wow.
either of the toothpaste. Again, somebody may say, well, how can that be? CPC, again, CPC is sensitive to ingredients. I just don't think there was enough in that toothpaste to keep the CPC available to do its job. Again, here in the OTC monograph for gingivitis, OTC levels, we're talking about CPC can be used, right? There's a certain level and there's a certain bioavailability and there's a certain format, only mouthwashes. Here, the toothpaste, we can't really talk too much about that.
Outside the US.
Outside the US, it's whatever somebody wants to
Wild,
try to
wild
make.
west.
It's the Wild West. Yep, good luck. Especially if it's not necessarily a global brand that is having a product.
Mm-hmm.
There
Mm-hmm.
may be a benefit, but there may not be. You know, the level again, what the level is in the for the CPC is 0.04, 0.045 to about zero point 0.1. And
Okay.
but the bioavailability has to be between minimum 72 and 77%.
So they're very specific.
Very specific. You know, unfortunately, a lot of the mouthwash, I mean, heck, we've even tested mouthwashes, commercial mouthwashes. They don't necessarily even have 72% at the baseline, but you know, that's that's the target. Again, from your reputable brands, the ones that have been around, yeah, their stuff has, and those formulations have been made properly. So the availability is going to be there. But if anybody has an idea, oh, I want to make a CPC rinse, okay, be careful, okay? Do some research, you know, reach out to us if you need to. If you don't, that's fine, but do your research because it sounds like it's a simple thing and it's not so simple, especially if you're looking for certain flavors. Okay, because
So
certain flavors will also, you and I know that from all of our work that we've done.
yes, yes, flavors can be very interesting.
Mm.
Overall, it sounds like CPC didn't quote unquote kill
Yep,
everything.
that's right. And it could just be because of the availability just wasn't there, right?
Yeah, okay,
And
that
let's be
makes sense.
honest. So even if we have to say, okay, let's ignore that toothpaste study.
Okay. So then what about the oral spray
Now that
CPC
is an
study?
interesting study, and that one even had higher amounts, 0.3%.
But okay. In the US, that's not
That's right.
okay.
So that would exceed what is allowed here in the US.
Okay.
This study was done in Japan. And so this was, again, a separate study. You could find this 2023. It was published in the Clinical and Experimental Dental Research Journal. And they were looking to see, hey, how does the microbiome get affected whenever you're using toothbrushing, especially on the tongue? They wanted to tongue scrape and stuff, but then they wanted to use a spray, the CPC containing spray after.
Okay.
And they said, okay, let's take a look at the microbiome there.
Okay. So we confirm this study was in Japan because
Yep.
0.3% CPC is much higher than what's allowed by the FDA here in the US,
Yep.
right? The 1 point or 0.1% CPC is the high end there.
Yeah, so is for us 0.1%. That's
Right.
right.
Okay.
So they use 0.3, 26 subjects per groups, two groups, and they looked at the flora or the biome, the microbiome after 1 and 3 weeks of use compared to the baseline. And you know, what they found is that the CPC spray significantly improved the abundance of Haemophilus, which is normally commensal. We don't usually hear about that type of bacteria, but again, there's many different genres. We already
Mhm.
talked about that there's over 700
Yeah.
species. You know, in general, this one is usually attributed to being commensal,
Okay.
and CPC spray significantly increased it. So it didn't decrease it. While the control, which did not have any spray, it actually had higher levels of a particular bacterium that they wanted to kind of throw out there. It was only recently, I guess, characterized and identified in 2015 as Sakura bacteria.
So a whole new one that we didn't know about, as
Yeah.
if 700 weren't
Yeah, but
enough.
exactly. So it's there. They're unsure if it causes pathogenic. Probably it's opportunistic, I
Okay.
would say. But those are the only changes
Okay, so it sounds like
on
what
the
I'm
tongue.
hearing you say is that the microbiome wasn't wiped out
Nope.
or even slanted towards
No.
pathogenic by use of the CPC spray,
Which
correct?
had 0.3% even. So it had
Times the
three
level out
times
here.
the maximum level allowed here. Yeah.
So everyone that's screaming that our oral microbiome is being killed by CPC, which is only allowed
Yeah.
point 0.1 here,
They need to relax.
can you relax? Because
Just
0.3 didn't even do it.
just take a minute, you know.
Okay,
Initially, right after use, you're going to have some broad spectrum killing of anything immediately right after use with some of this stuff.
makes sense.
But everything isn't killed and then dead and then wiped out and doesn't come back.
Right.
It actually sometimes goes into a quiescent state. And there's even such things called as persister cells, where they still exist. They're just going to hang out, wait for the environment to become more favorable. It's like a sunny day. All of a sudden, it's like, hey, now I can come out and play. It's this,
They're
it's
incognito.
the spider, right, on the, falling down because it was a rainy day. And then all of a sudden, the sun came out, right? And then the spider comes out. I know that's an awful analogy, but this is one reason why bacteria in general, I'm not just talking about in the mouth, are so hard to permanently kill. It's so hard to permanently kill bacteria because of these quiescent types of states, because of these persister cells. They
There's
just
so many
hang
different
out.
kinds.
Yeah, it's almost like they go into some kind of hibernation mode, and they're
Okay.
just withdrawal. They have low energy output, and they just maybe respire
Bide
just
their time.
very little, very slowly until the conditions are right. Yeah, I mean, this is the case again, not just in our mouth, this for
It's
anything.
the way our body
It's
works.
just the way bacteria works. So
Bacteria
bacteria on a shelf or on the TV if there's something there, if
makes
it's on
sense.
your animal, if it's in the dirt, if it's in water droplets in the air, this is just how it is. So that's right.
So that was mouthwash
Yep.
or I'm sorry, that was toothpaste and spray. So what about the mouthwash?
Yeah, so there was another study completely independent than the one that was done with that spray, but it was also done in Japan, and they looked at the effect of a 0.05%
Okay.
CPC mouthwash.
Which is still 5 times higher,
No,
right?
point
Or
oh 0.05 would
okay.
be
I believe it.
that would meet the minimum threshold because here in the US it's 0.045. So that would be the minimum
Okay.
threshold for here in the US if you wanted to have,
So
you know,
so it's something that's
it's something that has applicable,
okay, perfect.
and stuff to our monograph in here. So they wanted to say, okay, let's look at people with orthodontia. Remember how we just talked
Hmm.
about plaque traps?
They present numerous plaque traps and additional preventive measures like the point zero 0.05 CPC are going to be needed, right?
Yeah, that's right. So they looked at halitosis
Mhm.
factors, they looked at the tongue microbiota, and they had 30 participants per group. They had, and this is, I really like this. I really like this because not just because they use the CPC, but it was zero point zero 0.05 CPC mouthwash three
Mhm.
times daily for 1 month, or they use an exact mouthwash, an exact placebo.
Did they consult you for this
No, they
study?
didn't. They used an exact one that did not have the
The only
0.05% CPC.
brand
It was a,
study.
yes, and they looked at, that's right. So I'm always happy when I see that.
Of course.
Could they have taken a competitors or could they have just said, hey, we're going to take a sugar rinse or we're going to take a
They
salt
did it
rinse?
the right way.
They did it in a way that also accounts for all the other inactive
Yeah,
ingredients. Too many times, because those inactive ingredients affect
absolutely.
substantivity, they affect dilution, they affect the way that natural enzymes in our mouth degrade species that are found, like molecular species, those ingredients that are
Absolutely.
in the treatment, you know?
And that's why you like it so much when exact
Yeah,
placebos are
that's
used,
it.
because if there's only one difference between the two, then it's very easy to attribute
It's
that
very, yes.
cause and effect.
Yeah, this would be a higher quality study. If you go in front of a court and there's discussion about, hey, you made this claim, and somebody says, I don't like that claim. What kind of study do you think they would like to see?
Oh,
People who don't even study oral care products and
it's
know
common
nothing about
sense,
bio,
right?
like they're just going to be like, okay, were these, essentially identical,
Exactly.
toothpaste? Oh no, we just had this other, you see this. It happens a lot.
Yeah.
You see, and there's more and more papers that are just being published, I think, because some, especially academic papers, maybe they're just hungry to get that kind of funding. And they say, okay,
Mhm.
well, we're going to look at certain tooth tablets, maybe. And it won't be like, they'll be like, oh, our tooth tablet's great because it has HAP in it. And it's like, wait a minute, you used a sugar tablet as a control, which kind of slanted that because, I
Dr.
mean,
Rob Rant.
I know it's awful, right? But
No,
sugar isn't even allowed in oral care products. A lot of people don't even know that probably.
yeah, but
That
it's
is
great when
one.
you test against it, right?
Yes, it is. That's
So
right.
what did they find?
Okay, so they were looking at the halitosis metrics. In particular, they wanted to see, okay, was hydrogen sulfide evolved, methyl mercaptan? Those are two of the most, odoriferous molecules presenting with, halitosis, as well as the tongue coating index. They looked at microbiome composition, the plaque index, and the gingivitis index. Usually the PI and the GI, plaque index and gingivitis index, are definite criteria that you would want to see in any anti-plaque or anti-gingivitis clinical trial.
Okay.
Okay, so I really like the fact that they include those two.
Okay. So what about the microbiome in general? That's what we're
Yeah,
talking about.
yeah, because that's really what we want to focus on here. Well, CPC reduced the halitosis associated species that were causing, the hydrogen sulfide and the methyl mercaptan, right? What species in particular? It reduced the actinomyces, corynebacterium, and Tannerella. So it actually had those people
Those
that were
bad
using,
actors.
yeah, those bad actors, they had lower levels. That's consistent with what you see
I
in the
love that.
literature, but, and I love this part, I love this. The CPC rinse increased the beneficial species Streptococcus salivarius and Streptococcus infantis, Neisseria flavens, and Haemophilus parafluenzae, with the latter also being a nitrate reducing species.
Okay, so I think that part of that might be worth repeating. In other words, if I understand correctly, the CPC actually made your commensal or beneficial bacteria better.
Yeah, so
It improved your
it
oral
improved the
microbiome.
commensals and it pulled those opportunistic pathogens back to the level where maybe they could still exist in
That's really important.
a commensal way.
It's exactly opposite of what
Yeah.
everyone talks about.
Well, again, I wasn't affiliated with the study. There was no agenda here. We're just stating what is in the literature. Are these well-designed studies? I'm choosing well-designed studies.
I like that.
Notice how I'm not choosing, well, I saw this planktonics on one
Right,
species where
right.
it was in an agar plate and we put the active ingredient there and oh my God, it was so good. Again, those studies are great entry levels. They give you an idea. You have to start somewhere. But if you really want to progress, really the narrative for that active ingredient, you got to formulate because you have to be able to account for dilution. You have to be able to account for substantivity. Things are going to react differently in a format,
When combined with other,
whether it's toothpaste,
right.
oral spray, mouthwash, whatever it's going to be.
However,
However,
all three of these CPC based studies, very different, all well designed, they all showed beneficial oral outcomes. In other words, even including the oral microbiome, it's actually beneficial and not this horrible assassin that everyone's trying to make it out to be.
yeah, we're not depleting ourselves of that, right? Short term, immediately after use, yeah, you're going to have some dramatic effect. In fact, now I want to talk about that Listerine study. So Kenvue is the company that now produces markets the Listerine. Previously, it was Johnson and Johnson, and at one point it was Pfizer, and then it was, of course, it was Warner Lambert even before that. Okay, so there's been iterations of ownership, right, and direction with this, but Kenvue now has that. Well, they recently published in 2024. Again, I love these open access journals because there's not a paywall. So anybody who's interested, the
Yeah,
formulators, I know formulators will go and look at the patent databases. That's how they get inspired sometimes, at least historically,
sense.
you know, because that's what was available. Now, with just everything is becoming more available. I mean, even the AI generated stuff that you
Mhm.
get in doing a Google search is every day it just gets better and better. But these open access journals are nice because you don't have to worry about the paywall and the data's there. So
It's great
the data's
reading.
there. You can see that. They looked at four different types of their Listerine brand. And they
Okay.
wanted to look at, well, what was the effect on the oral microbiome over 6 weeks of use? They had a negative control, Kenvue, and I like this too. A great negative control sometimes is a 5% hydroalcohol rinse.
And why is
Not
that?
not too much alcohol, but just enough because it's better than water because of your Listerine and you use alcohol and your
Okay.
with your essential oils because that's what the monograph allows for. It kind of says, okay, well, alcohol was present. We just kind of cut it back, and we're going to use that
It tries to balance it,
as a
make
nice
it
negative control.
okay. That makes sense.
So they looked at that, and then they looked at Listerine Original Cool Mint. Again, next episode we'll talk about those ingredients, but that one has the 21.6% alcohol with the four essential oils. And then they looked at two formulations of Listerine, one without alcohol and the that had some alcohol, but it was a bit different composition. And they wanted to look at,
Okay.
well, what was the effect on the microbiome? Not only the normal healthy commensal stuff, but those affiliated with maybe halitosis, maybe acidogenic species, maybe those affiliated with plaque, and they looked at all that.
Okay.
So,
So what they find,
well, 4 to 6 hours, everything dropped, you know,
which is expected.
including the 5% hydroalcohol. So even that comes down. And
Okay.
oh, by the way, it wasn't just microbiome. They looked at the plaque index and then the gingival index.
Okay.
And I believe they looked at the bleeding index too. Those are also like bleeding on probing and stuff. That's how you kind of know if you have gingivitis or not. But gingivitis, by the way, and this is sometimes like a silly thing, that's a reversible condition. Like gingivitis is not as serious as caries. Of course, maybe somebody in gum health might be like, no, it's not true, but it is true because gingivitis can be readily reversed, right? And small cavitations
Well, super
can be,
small,
yeah,
right?
super small as long as they don't penetrate into the dentin.
Yeah.
But you got to make sure that you arrest them too and then
Hmm.
remineralize. They can be repaired. You need fluoride for sure to help with that. Again, there could be some pushback there, but look, we're just basing on what is allowed. Okay.
And what the science
These
shows.
are the rules in the game in which we are. And until somebody does a new drug application and says, hey, I can regrow the teeth that has the enamel, we're going to continue to follow the rules because it's too much whenever a
Hmm.
competitor will call you out and then you have to back up your data. And it has been done, it continues to be done. And there, it just pays to know what is the arena in which you're paying it and
Correct.
playing in, what are the opportunities. Anyway, the whole point is after 1 week, 4 weeks, and 6 weeks, all the microbes recovered. Maybe not to the original level. The acidogenic ones, though, did within 4 weeks. They immediately pop back to the levels that they
Okay.
were affiliated with within 4 weeks. For the other commensals, they're coming back. Maybe they're not there 100%, but it looked like based on the bar graph that I saw and stuff, maybe it was anywhere between, I don't know, probably 75 and like 90%. So they even, came back too. But really, it's the alcohol, I think, that's providing some of the extended delays in the recoveries,
And the negative
right?
control helps to demonstrate some of
Yeah,
the
it kind of
stuff.
does. Yeah, because you can take a look at that and you can
Right.
say, oh, wow, well, the negative controls, it's coming back, but,
Right.
that only had 5%. These other ones have like 20%. But it's interesting. So even with the higher level of alcohol, the microbiome is coming back. What does that mean?
Well, it doesn't sound like things are wiped out for long periods, right? So even with the daily use, and I think this study was 3 times a day. Forgive me if I'm wrong, but it was definitely over
Just
6 weeks.
twice. In,
Okay,
the, in
twice
this
a day,
particular one, I believe it was twice.
twice a day,
Yep.
but it was 6 weeks, and you put daily use over the course of several weeks. So not everything was wiped out. It
Yeah.
started coming back.
Yeah. And I think that it's really important that we understand that the microbiome is going to evolve to the treatment.
It's not static.
So here's the question. So in 4 to 6 hours, if everything was wiped out, why didn't it stay wiped out?
I would say partly because we introduce new things to our mouth all the time.
Well, yeah. So the treatment, yeah, it's only going to have certain reside time, right? Substantivity is going to be there. We talked about some other like proteases that can actually degrade things. There's going to be limits, but it just shows you that the oral microbiome is highly adaptable, man, and it's going to evolve to your treatments. It's going to evolve. But that's where some of this distinction, you know, might be made. So while things might be able to respond maybe faster to CPC because of lack of alcohol, the Listerine will then be slower. What about something even more aggressive like chlorhexidine or some of these chlorine dioxide gases? They might even take even longer for those species to come back to original levels if they
Hmm.
ever get there.
Yeah.
So the duration and how long, like how long does the evolution of the microbiome take? It's going to be predicated on all of these different treatments,
So many variables.
But even with 20% alcohol, which admittedly is a lot, it still came back. Like maybe not to full strength, but it is coming back. There is some evolution. So
Okay.
I think that that's really important. Just, to just specify.
Right. So probably the most important take home would be then, at least here in the US, not all conventional oral care treatments are going to be bad, right? There are those that are potentially more damaging that have maybe a chlorhexidine in it. But those aren't readily available here in
No,
the
they're
US.
not,
So,
and you can choose, right? You can choose which ones. There's even mouthwashes that are more slanted towards whitening, so you'll have peroxide in there.
okay.
You know, the peroxide will probably have more of a damaging issue, not on the microbiome per se, but on your gum tissue.
Yes, I can see that.
I know of a story I was told by somebody. This person was adamant about whitening their teeth so much that they actually almost had like white gums
Oh,
because
no.
they were using I don't
How
think I
painful.
think they were using actual hydrogen peroxide, like straight up, like maybe 10% or 30% that you could get if you had access to those kinds of things. But it wasn't like a dental product. It was they wanted the white teeth, but it just bleached everything, you know? And so, obviously there's going to be some concerns there. So if you are using a mouthwash that has even 3% or 4% or 5%, you might have an exacerbated microbiome response because you're actually having a soft tissue response too. You'll know. But again, that's for those that really want that whitening and they have to, anybody doing and participating in a whitening event, they're going to have some additional considerations that they got to worry about, right? I just think that, now what it has to do if we know that all these mouthwashes exist for many different reasons, and there's some mouthwashes that have no active ingredients in there. Somebody will put a aloe vera in there and they'll say, "Hey, it's great for this." I don't know about that. Where's your data? I would like to see the data.
It's
And then,
always about the data.
you know, if that's the case, then maybe I'll try it.
Hmm.
But they'll say like, "Yeah, but it has like 20 or 30% aloe vera." Okay, that's nice, but I don't know if it's doing anything
Right.
good or bad, you know? Um, what we need to do is we need to understand what is allowed
Hmm.
and what the clinical testing is looking like and understand that the microbiome, the oral microbiome, is highly adaptable and you're never going to completely wipe out these species. We talked about that, right? These quiescent cells, persister cells,
The
they
sleeper
exist.
cells.
They sleeper, yeah, the sleeper cells, they have this. And I think that with an understanding of that, you can start generating maybe a particular type of strategy, an
Okay.
oral care strategy. What I've seen, and this is just based on my review of what I've seen in the literature. I think way back when we talked about triclosan, with Colgate, we said that there's an incubation period,
Yes.
right? Like triclosan, the full benefits of that aren't going to be observed necessarily in the first week of use. In fact, it's going to take maybe 3 months for you to get those
For a
really
while.
great results. The results may persist as well. Maybe there's going to be certain indices that continue to improve, but the microbiome will adapt to that. And it'll probably accommodate the fact that it's having this treatment and is not going to go, crazy. How do we know that? Because the clinical studies show that you're
Right.
not getting worse clinical parameters like, plaque index, bleeding index, gingival index. Those aren't increasing with extended
Mm.
use. Of course, the triclosan, you have to worry about other factors like, I don't know, cancer,
Cancer.
you know, but
Don't worry, it's
but
legal.
that's yeah, but that's not allowed to be used, right? It was
Right.
pulled, right? But if you're looking at, say, the CPC, especially, or even Listerine, and we even talked about it with that 6 week study, everything starts to come back. I've seen, based on my reviews, that usually 3 months, you're pretty much going to max out almost where your benefits are going to be.
Okay. So there's a trend.
Yeah, and I think, not that you can't still get improved clinical parameters
Right.
like a gingival index or plaque index, but it's gonna be saturated at some point.
Okay.
Everything is adapting. Everything evolves. And by the way, it's interesting, 3 months, because that's what the American Dental Association recommends for their seal. If you're gonna do a gingivitis trial, 3 months. Not
Ooh.
3 weeks, not 3 days, not 2.5 months, not 2 months, not 1 month or 1.5 months, although that could be great, great, great pilot data. We want to see 3 months because
Okay.
the body has to be able to accommodate. Your biome is shifting, everything is maturing
So
and
they know
evolving.
this.
Yeah, I think so. And that's more of is it really necessarily long term? 3 months is still pretty short,
Yes.
really. But if that's the minimum and that's what you're seeing is going on, then I think that that's a reasonable thing. You know, CPC. Okay, so somebody might say, well, how do you know? How do you know this? Well, in the American Journal of Dentistry, had a publication in 2005. This is a study done by one of my mentors, Stuckey. He had published on this, and this was done in conjunction, I think, with Procter and Gamble, I believe. They were looking at CPC rinses, zero point zero 0.05, or sorry, 0.075
Okay.
CPC and zero point 0.1.
Okay.
So at the highest level, at the
Right.
monograph, and then the next lowest. And then they also looked at chlorhexidine. And they had these four different legs, right? Because they also had a placebo in there
Okay.
as well. So you had four groups of people, four cohorts using these products for 3 months and 6 months.
Okay. So it was well
The
designed.
plaque index and the gingival index ceased to improve by the 6 month mark. At 3 months and six
Wow.
months were really similar, not only for the CPC, but also for the chlorhexidine group.
Okay.
So this is kind of why I'm saying, well, maybe there's a sweet spot here. Sweet spot for what? A sweet spot for innovating on how you can have a brand. So if you're a formulator, if you're a marketer, if you're somebody that wants to start a new company, has a new company, and you want to differentiate yourself in the
Yeah.
market, instead of trying to say, hey, all these mouthwashes are bad, man, let's use the data that we have and understand and start making more,
Strategic.
strategic, yeah, just more focused and more creative, more innovative ways to say, well, how can we help improve somebody's microbiome or just general oral health and all? So how might we do that?
Well, because based on everything you're saying, it sounds like the microbiome actually evolves or changes or
Yeah, that's what
recuperates or
it
whatever you want to
recuperates.
say.
Yeah, yeah. Choose your verb, but don't choose the verb dies because again, even there with the chlorhexidine, the chlorhexidine still didn't like the plaque index and the gingival index, it didn't increase at 6 months.
Right.
It just stayed right there.
Okay.
So it's not like everything's wiping out and or whatever, but still, don't use chlorhexidine. I would say stay away from chlorhexidine.
So it sounds like you have an idea.
Yeah, I mean, I think that if it's 3 months, well, that's awfully similar to how many months there are
Season.
in a season. I think it would be really neat to have a seasonal variation in products or a regimen that would take advantage of that, knowing that the oral microbiome will adapt, it will evolve, and depending on what the season is, especially if you're in a climate changing or, a
Right.
season changing climate, we're not, dead set at the equator, we're not at the North Pole, maybe having a different kind of regimen that maybe fosters maybe different active ingredients, maybe different approaches, maybe use CPC for a bit, maybe use essential oils, maybe use something else, maybe nothing. Maybe use peroxide, for instance, that we were talking about, or maybe if aloe vera does well for you, right? Use
Mhm.
that. But then you can start having fun with it, right?
Well, so I'm gonna follow the bouncing ball, as you often say. It sounds like, based off of what you're saying, that if our oral microbiome tends to adjust or get adapted to or used to whatever it is we're using around that 3 month mark, then why don't we switch it up on
It's like
those
exercising.
microbials,
That's what
right?
everybody says, Oh, you don't want to run for the same distance every day for the same amount of
You
time. You're
have
going
to
to wear
mix
out
it
your
up.
body, right? Sometimes they say, well, then mix up your exercises.
Okay, so you mix up your
It
oral care
follows,
routine.
mix up your oral care routine, Try using different products,
Okay.
Use safe products and hopefully use products that have been tested, because you don't want to be a guinea pig. And for somebody
No, not
for
even
somebody
food
who
restricted.
has products, well, they said that they use science-backed ingredients. Yeah, but did they test their product? No.
Yeah,
Oh,
no,
okay.
most don't. Right.
Yeah, yeah.
Okay.
Yeah,
So
thanks, Boca.
that that's a really interesting concept.
Yeah, I don't know. It's just something a little bit different, but that's a strategy right there that I'm trying to leap to just kind of drip in. Obviously, the big companies can't do that. There's supply chain issues.
Hmm.
It's just too hard for them to organize all that. But for somebody nimble and hungry and eager to make a differentiating brand, a
Yes.
differentiating stance in a marketplace that can still be science backed, that can still be consistent with what is allowed in the FDA, and that you can get claims that are reasonable. The stuff that's in the OTC, that typically means as long as you're following that, you don't need to run all these clinical trials. That's what they
Okay.
also don't know.
Right.
If you are adhering to the monograph, you don't have to run all of these clinical trials
Because you're not making outlandish
because
claims.
you're trying to stay within the parameters, and that's why the OTC exists. It's actually one of the best tools out there for any formulator, any brand, anybody who has an idea for this stuff. Stay
Wow.
within the confines. And you can, and there's variations. You have, even with CPC, right? 0.045 to zero point 0.1. And heck, you could even put CPC as an inactive ingredient in your
Yes.
toothpaste if you want some kind of preservative, for instance. There are creative ways to do these things. It's just but that's where the creativity should be. Let's figure out how we can keep with the OTC monograph. Maybe we can keep our eyes open for anything else. But again, if it's not in the monograph, please get it tested.
Yes. Yes.
Formulators, think about this. Don't just say, well, it worked for shampoo and we're going to do this and shampoo doesn't get tested. Or, oh, I did, here's what formulators will test. Oh, we tested on the skin and it absorbed well. Or, well, we ran it in one of these PET challenge tests, which is a preservative efficacy
Okay.
test that they do. And yeah, it didn't grow any, it's safe to use. But that's only about safety. How effective really was it?
Right. Those are two completely
Those
different
are
things.
completely different things. You should be doing PET, challenge testing, but you should also be doing efficacy tests. And there's ways to do that. If anybody wants to know, they can always reach out to us.
Yeah.
Right?
Somewhere.
That's easy. We'll probably talk about some
Yeah.
of that anyway at some point, but
Well, I think somewhere out in the internet land, there's an influencer that's going to latch onto this very bougie idea of
oh,
changing with the seasons or
yeah, I mean,
something.
to me, I think
It's clever.
yeah,
I love it.
I
It's
just think
just,
it's,
I can see you making
I
it
think
a
it's,
very fun thing into it.
yeah,
Anybody could.
in the low seasons where you don't have much vitamin D, put more vitamin D into your toothpaste. I mean,
Right.
there's so many
Smart.
different things. Like
There's definitely
there's
creative
so many
ways.
things to do. Anyway, all right. Well, for now, I think that wraps up this part of the microbiome. I think what we'll do for the next podcast is we'll actually look at some of these mouthwashes because we've been doing a lot of talking and we're
Yes.
going to do some forensic formulating. So we're going
Oh,
to take a look at what all of the ingredients again
break
do
it
and
down.
just break them down. And we'll just say, hey, what's in these? We'll probably look at CPC. We'll probably look at Listerine, a couple of different Listerine formulations, and we'll go from there.
I
But
love it.
does that sound good?
Absolutely.
All right. So for now, that is it. We really appreciate you guys listening. Again, reach out with questions. One of the reasons why we're jumping on the microbiome is we've had commenters who said, "Hey, we want to know more about that," and so kind of just throwing that in. But this topic is huge, absolutely huge. There's going to be things that I don't know, but there's also going to be, of course, I mean, there's you know
Sounds like there's a lot of
nobody knows
opportunity.
absolutely everything, but we got to try to figure out, well, how can we understand this in
Yes.
a proactive way so we can better understand these formulations. All right. So, and with that, that's it. I'm Dr. Rob and Tammy's here, and thank you for listening to Dental Formulators Playbook, and we'll catch you next time.
Thank you.